The majority of older patients with AML have inferior outcomes and poor outcomes really with standard therapies. And so the importance of clinical trials can't be overestimated. And there are several different clinical trials right now available for patients with an IDH2 mutation. In newly diagnosed, older, or otherwise unfit AML patients, there's Vidaza in combination with an IDH2 inhibitor under evaluation. For younger or fit patients, there's the standard intensive chemotherapy with an IDH2 inhibitor ongoing, and there are several combination studies either opening now or soon to be open of the IDH2 inhibitor with various different combinations. For instance, patients with FLT3 mutations also with the addition of a FLT3 inhibitor, and so on and so forth. This patient's response to intensive AML therapy is unfortunately rather typical, and that is we were able to obtain a remission. We do that the majority of the time. Patients are able to obtain a remission, although a lot of times that is short-lived, and patients within 6 months to a year after therapy unfortunately relapse. And so it tells us both that we need better options for our relapse patients, but we also need better upfront combination therapies for patients so that they have more durable and lasting remissions in the first place. And so that's hopefully where the impact of these IDH2 inhibitors will be seen in the future. So the IDH2 inhibitor was approved as a single agent in the relapsed refractory setting, but my hope for the future is that it will be able to be added with combination therapies in the frontline setting and lead to improved, more durable first-line remissions. In a patient who's received standard intensive chemotherapy, who has relapsed quickly after cytarabine-based chemotherapy, giving more intensive therapy in general is not warranted. They've proven themselves to be cytarabine refractory, and so options in general are hypomethylating agent therapies, things like Vidaza or Dacogen, decitabine. These are available and do provide responses in some patients, often not particularly durable. Or now for IDH2 mutated patients, the FDA-approved enasidenib, or now IDHFA, is available and is an important consideration for these patients for sure.